Everybody to the University of Washington Psychiatry and Addiction Case Conference for August 17th, 2017. It's nice to see everyone who is joining us today. So today we're doing our typical agenda where we'll have our presentation. We're fortunate enough to have Dr. Susan Collins. Aaron, I think you're making a lot of noise over there in the corner. You might put yourself on mute. We're fortunate enough to have Dr. Susan Collins joining us today, clinical psychologist and a real specialist in harm reduction. Rick and I work with her a lot, and it's a great privilege to have her join us and talk and give her a kind of presentation and thoughts on this topic. She did last year, and I thought it was really useful, and we had a lot of good feedback, so it was great that she's able to join us again. So after that, we'll have our roll call, and then we'll have some time for cases. We do have one follow-up case that we'll be discussing that was initially presented back in April. But after that, we don't have any scheduled cases. So if there are cases that come up during the presentation and you'd like to talk about, definitely make a note of that, and then we will be able to get to those later after the presentation. If you have questions or comments during the talk, feel free to raise your hand, interject, type a comment in the chat box, and we'll try to get to those as much as we can. Also, if you're not making a comment, though, please keep your mics on mute because it makes it a lot easier for everyone else to hear. And then if you're making a comment, it's great to see your face. So if you have a video camera and able to do that, turn on your video so we can kind of all improve our just to get to know you a little bit more and just kind of build our own community. So I think with that, we will move on to our presentation. Here on my end, it's Rick and I, the medical directors here for the PACC session. We're not going to have any residents joining. I don't know if Carrie Stevens is joining us today. I forgot if she's in or out, but she may be joining us a little bit later. Rick is, there she is. All right, great.
Thank
you. On cue. I was just saying, I didn't know if you were making it today. But Carrie Stevens here, our clinical psychologist and regular panelist as well. So with that, I'm going to turn things over to Susan to more fully introduce herself and get started with the presentation. So take it away.
Thank you, Mark, for the introduction, and thanks for this opportunity. Today, I will be talking about harm reduction for substance use. The idea is meeting people where they're at, both in their communities and in their motivation for change. As Mark mentioned, I think you mentioned this, Mark. I'm faculty here at the University of Washington. I work at a Harborview Medical Center. I'm a licensed clinical psychologist, and I co-direct the Harm Reduction Research and Treatment Center. I also work in the clinic here at Harborview, doing harm reduction out of our addictions and mental health clinic. So full disclosure, I have no actual or potential conflicts of interest in relation to this program or presentation. And today, just to give you all an idea of where we'll be going, first I'll provide a definition of harm reduction and harm reduction treatment. I'll provide the rationale for harm reduction, and as an introduction to some clinical tools that we have used that we've created an evidence base for through our research here at the University of Washington. And then, of course, there will be time for case consultation as well. So harm reduction can be applied to various behaviors at various levels of intervention and across various types of substance use and modalities of substance use. Most often, we think of harm reduction as being applied to risky behavior, so thinking about risky sex and substance use. Today, I'll be focusing the talk primarily on substance use, although there are a lot of overlapping behaviors that make this relevant across different types of behaviors and different types of patient populations. But to kind of put some parameters on it, we'll be talking primarily about harm reduction and substance use. Harm reduction can be described as a set of strategies. It is a grassroots and user-driven set of compassionate and pragmatic approaches that aim to reduce substance-related harm and improve quality of life without requiring abstinence or use reduction. But it really is more of an attitude than a fixed set of approaches. It really is more, we express the harm reduction philosophy more in the way we sit with clients and the way we advocate on behalf of clients and in the way we talk to people that we're working with. The philosophy behind harm reduction is compassionate. So there are a few fundamental beliefs that we as harm reductionists hold. that are important just to remember in our day-to-day practice in doing this kind of work. So we understand that substance use has its pros and its cons. Our clients use for real reasons that are important in their lives, and we acknowledge those as much as we also acknowledge some of the drawbacks of their use or the not so good effects. And this is important for a couple reasons. First of all, of course, it helps us build rapport. I think Bill Miller has pointed that out in a lot of his work, that we understand clients' perspectives on their own substance use. But it's also important for us in terms of doing the clinical work, because if we understand what clients are getting out of their substance use, we might be able to help them, if they're not ready, willing, or able to stop using, be able to obtain some of those positive things that they like while minimizing their experience of the negative consequences. And also we can help them to understand alternative ways, non-substance using ways that they can achieve some of those positive things that they want to see out of their lives. We also acknowledge that substance use is here to stay. So instead of spending our precious clinical time trying to eradicate a behavior that's been around for millennia, that we really want to do what we can do as clinicians in this moment to reduce substance-related harm for our patients, our clients, and the communities they live in. We acknowledge that substance use is complex, so it is not just a disease that resides within the individual. It is a part of a much larger system with complicated transactional effects between the individual and all of the various factors that they have on board, as well as their interactions with familial contexts, community contexts, and even larger geopolitical contexts. And that brings me to the point that substance use exists in the social context, right? So this is a social construction. A lot of the constructs that we have in substance use, including what are illicit substances, that changes from time to time, that changes from culture to culture. Also what we consider to be a substance use disorder. And a most salient example of that is when we switched from having alcohol dependence and alcohol abuse, or substance dependence and substance abuse in the earlier DSM-4, and now we're talking about substance use disorder. And that's really changed who we are actually pathologizing within our own institutions and within our own professions. And so because substance use really is a part of a much larger social context, we need to remember that substance use is not the client, and the client is not just their substance use. There's so much more to clients than just that. And so really focusing on helping clients understand what they want to move towards as human beings and supporting that to the best of our abilities. What we found is if we do that as clinicians, through our research, we found that that helps people start to make positive steps towards behavior change in terms of their substance use. And let's see if I can, there we go. The approach of harm reduction is also pragmatic. So we focus on harm reduction versus use reduction. I'll talk about that at greater length, both why and how we do that a little bit later in the talk. We also focus in harm reduction, not just on what clients should move away from, that is moving away from substance-related harm, but we also want to focus on figuring out what they want to move towards. So we really focus more holistically on the client in terms of their quality of life. Harm reduction is really client-driven. We move towards goals that clients want to see happen for themselves. It entails advocacy for social justice and racial equity. This goes back to recognizing the fact that the social context really does influence substance use, who is pathologized with substance use disorders, who is incarcerated for substance use disorders. And so acknowledging that and also speaking up for our clients in otherwise oppressive institutions and systems that they are a part of. And harm reduction is also open to the power of any positive change. So for mainstreamers like me, I'm a 9-to-5er, I am upwardly mobile, I am well educated, and I have a lot of privilege in my life. I work with a lot of homeless individuals, and so as a mainstreamer, I might see certain clients' positive steps towards behavior change as small baby steps, but really for them, they might be leaps and bounds. So for me, it's about adjusting my understanding of how the world works and my set of values to really acknowledge the positive changes that clients are making on their own terms, on their own timeline. I want to acknowledge as a harm reductionist that harm reduction can be practiced at various levels. It can be practiced at the policy level, and examples of harm reduction at the policy level include drug decriminalization, legalization, and regulation. At the population-based levels, you can think of PSAs, public service announcements. A perfect example of this, if you can remember the 80s, is the MAD PSA, friends don't let friends drive drunk, right? So the idea there wasn't that Mothers Against Drunk Driving were not saying don't drink on the weekends, but they were saying please don't get into a car and put yourself or other people at risk. And that reaches a large population. It's not focused on the individual. You could have community-based harm reduction interventions, and examples of those would be, for example, Housing First projects, providing low barrier, non-abstinence-based housing to communities, and that improves community well-being as well. And another example would be very important here in Seattle right now, the idea of safer injection sites. These are interventions that exist within communities for communities, but that also benefit communities. But today I'll be focusing on individually based harm reduction intervention. And that's because I know everyone on the call is in clinical practice with patients, with clients. And so this is the way in our professional work often we're going to be doing harm reduction, if you will. That being said, I also want to say as a harm reductionist, we should be advocating on these other levels as well and really trying to explore what can we do to decrease substance-related harm and improve quality of life through these other types of modalities. So because we're focused on individually based harm reduction today, our focus in clinical work, as you know, is really how we talk to people, right? And so today I'll be talking about harm reduction treatment, which we call HART, and is a modality that I have worked on developing over the last, I think probably 7 or 8 years now, together with Rick and with Mark, who are organizing this great seminar. And over the years, we've adjusted this modality to fit across various settings and different kinds of providers so that everyone can be a part of harm reduction treatment, regardless of the specific work they're doing on the ground. And in terms of thinking about physicians and nurses and how y'all can be involved in harm reduction treatment and how you can do this and integrate this into your practice, for example, today we have a lot of great medications, a lot of great medication-assisted treatment that can really help clients. Has anyone else seen this toolbar across the bottom, or is that just for me?
Yeah, we can see the bottom medication bar, Susan.
Okay, I couldn't, so I just adjusted it. So at the bottom here, you can see medications that probably a lot of folks are familiar with. We have I also added e-cigarettes because we're doing that in a trial right now, but Vivitrol for use with alcohol-dependent clients. We have Suboxone, methadone, and naloxone. These are all ways that we can use medications to help people reduce substance-related harm. But of course, what we need to do in conjunction with administering these medications and prescribing these medications is also talking to folks in a way that is congruent with harm reduction. And so this is what I'll be talking about today is what is sort of the psychotherapeutic adjunct that you can use together with these great medications that we're using in practice these days. I do get the question sometimes when I'm doing trainings, well, aren't we already doing harm reduction, right? So there are a lot of folks who are working on the ground with active substance users. I think, you know, traditionally when we think of CD counseling, we think of substance treatment. We're oftentimes thinking, okay, if a person's not ready, willing, or able to get sober, then they're probably not going to be coming to our practice. And of course, I recognize that for most of y'all listening today, that's not really an option, right? So if you're in mental health counseling or if you're doing primary care service provision, you see clients whether or not they're active substance users. That being said, today, I think Rick put it best when he talked about, right, there's a little lowercase HR and a big a capital case HR. And today we're going to be talking about the big HR. There is a certain way of practicing harm reduction that is different from just tolerating the fact that people are using substances, but it really is actively working with substance users on substance use problems, but in a very different way from abstinence-based treatment modalities. So harm reduction counseling is not the same as the general principle that we all should be following, right? So do no harm or wanting our clients to experience less harm. Again, it is a specific set of concrete techniques that we have created an evidence base for. It's also about changing the spectrum of behavior change we're working on with clients, and I will really go into that very specifically. So what does it mean to be working on reducing substance-related harm instead of working on reducing substance use in and of itself? Also, these days, there isn't much training out there on harm reduction, and there are very few resources for fidelity. We're working on that right now at the University of Washington, and I'm happy to share with Mark when we have more resources available for that. But we're working on more trainings and more ways to help practitioners take this practice on board and then keep a lot of integrity in their practice of this over time. So just to be clear then, when I talk about what is harm reduction, I like to also talk about what it is not. And this is not because I want to call out other treatment modalities as wrong in any way, shape, or form, but it's really nice to be able to circumscribe. So if harm reduction isn't abstinence-based treatment, what is it? And it kind of helps to talk about what are the differences between what is typical in substance use treatment practice and what harm reduction kind of brings to the table. So harm reduction treatment is not relapse prevention or a mindfulness-based intervention in and of itself. It isn't CBT or brief interventions or SBIRT, motivational interviewing, or contingency management. And again, I want to emphasize that all of these treatment modalities are very important and actually very effective treatment modalities. Most of these have a very strong evidence base behind them. But they are helpful for a certain subpopulation of substance users out there, namely folks who are ready, willing, and able to achieve sobriety and maintain it. Or in the case of SBIRT, folks, or motivational interviewing, folks who maybe aren't ready to stop using, but are typically not as severely affected. So where I think harm reduction brings to the table is it is an intervention that you can use with folks who are pretty severely affected with alcohol or substance use disorders, but who aren't ready to stop using altogether and aren't ready to engage in traditional abstinence-based treatment. And so sometimes folks are asking too, what is the difference between harm reduction treatment and motivational interviewing? And I think that really gets to the crux of the difference between all these types of interventions and harm reduction, is that all of these other types of interventions really emphasize provider-driven goals. Namely, we as clinicians typically want people to get sober. We want to help them get sober and help them maintain sobriety. And in harm reduction, we are driven entirely by what substance users want to see happen for themselves. Now, that's not to say we don't have an agenda at all, right? So obviously, we do have an agenda because it's called harm reduction. So we do want to help people reduce their substance-related harm and improve their quality of life. Those are the two pillars of harm reduction treatment. But as you can probably guess, those are pretty broadly conceived, and those can be really tailored to help a person achieve their own personal goals and reduce substance-related harm in a way that is relevant, achievable, and desirable for them. And so going back to my earlier point, I kind of left off here on motivational interviewing. What differs motivational interviewing from harm reduction? And I think Miller and Rolnick really addressed this nicely in chapter 10 of MI3, which if you haven't already read motivational interviewing edition 3, I would highly recommend it. And in that chapter, they talk about when goals differ. And what they're referring to is when goals of a provider differ from the goals of a client. And Miller and Rolnick talk about wanting to look at that discrepancy and then resolve that discrepancy in the direction of positive behavior change. And typically, they decide that positive behavior change is most appropriately defined by the clinician. So therapists from a humanistic or existential orientation, there you can read harm reduction, might object to the directional aspect of MI, whereby clients are intentionally guided towards what the counselor regards to be appropriate goals. So that's just something to keep in mind. Miller and Rolnick prescribe a very a wonderful way of talking to people in a different light, but it is a kinder, gentler way towards use reduction or abstinence. And so to differentiate between the two, when we talk about the difference between use reduction or abstinence orientation in terms of goal setting and harm reduction goal setting, in use reduction or abstinence-oriented modalities, the ultimate goal is abstinence, although sometimes with less severely affected populations, maybe SBIRT populations in hospitals where we do opportunistic interventions in ER settings, or with heavy college drinkers, we might say, okay, we can stop short of abstinence, we can talk about moderate use. typically along the spectrum, we think that abstinence is the most desirable goal along that spectrum. Use of problems in this perspective are believed to be in one-to-one agreement. And both the treatment and the treatment goals are prescriptive. So the provider prescribes the treatment and the treatment goals, which again, typically go back towards use reduction or abstinence. And in this modality, the doctor knows best, right? The provider knows best. In harm reduction, on the other hand, our goal is harm reduction versus use reduction. We believe that the risk of problems that people experience is variable and individually based. And I'll again go into more detail on that in just a moment. Our role then is seen more as predictive. So our job is to take into account this larger context within which a person is using and help them assess their relative risks for harm based on the type of substance they're using, the modality of use, and their larger social context. And within this approach, we believe that the clients know better. The clients know their own context better than us, and can, if they are given the chance, they often are really able to make use of what we call a self-righting reflex. So I want to go back to this idea about the assumed one-to-one correlation between substance use and substance-related harm. And in this, I'm drawing on a picture that Rich Sates made up, I think, a few years ago. And also the step care model is something, obviously, that's been around for a few decades now. Came out from the Institute of Medicine back in, I believe it was 1990. And within this sort of step care model, there is an assumed one-to-one correlation between the level of use. So if a person's not using, it's assumed that they have no problems. If a person is using a minimal amount of alcohol or substances, it is assumed that they are experiencing minimal problems. Moderate use is associated with moderate problems and heavy use with severe problems. But what we found over the course of the last couple decades is this doesn't necessarily hold. I did a literature review a couple years ago for NIAAA and their current reviews, the National Institute on Alcohol Abuse and Alcoholism, and I reviewed the literature worldwide on socioeconomic status and alcohol use and people's experience of alcohol-related problems. And what we found was that particularly in dominant cultures in a society, and again, this was around the world, so that meant different things from culture to culture, but in this particular part of the world, we're talking about white and affluent drinkers, we found that they could be consuming exorbitant amounts of alcohol, just very heavily using alcohol, but experience very few alcohol-related problems. Whereas in more marginalized communities, in communities of color, in lower socioeconomic communities, we found that people could be engaging in lower risk use, but still be experiencing a disproportionate number of problems. So we found that this traditional one-to-one correlation doesn't usually hold. And because of this, we feel that the one-to-one correlation kind of inaccurately simplifies and confuses the issue of what kinds of harm people are experiencing due to their substance use. So the idea is, as a harm reductionist, you kind of toss that out, and really what we're focused on, instead of focusing on the amount of use per se, is focusing on the level of harm that a person is experiencing and what kinds of behaviors are leading them to experience that level of harm. I also want to provide folks with some reasoning and rationale behind why we as harm reductionists are practicing in this way. And first of all, because a lot of our abstinence-based approaches can be disempowering to folks. Now, again, there is a small subset of the larger group of individuals in the United States, at any rate, who really benefit from abstinence-based treatment, traditional abstinence-based treatment with detox and 30-day or 90-day stays in inpatient and followed up with IOP. This can be very valuable for certain people. But in some of our treatment communities, sometimes these approaches become more punitive towards the clients than I think they were originally meant to be. For example, this is a notice that was placed on the wall of a substance use treatment agency that I worked at a few years ago here in Seattle. When I was doing a relapse, I was providing relapse prevention treatment within the context of a trial that I was conducting with my late mentor, Alan Marlatt. And this was in the break room. So this was above the coffee maker. This wasn't something that clients saw, but it definitely, I feel like the break room of any space is like the mothership And this felt like it was an unofficial motto to me. So our clients are very sick and they often lie to us. What you can see what this demonstrates is this is sort of, the first part is like the disease or medical model of how we think about substance use, substance users, and substance use disorders in the United States. Our clients are very sick, they have an illness. And this illness is so pervasive and so insidious that it causes these character flaws or defects. And that brings us to the moral model of substance use. So this illness makes them do bad things, makes them lie to us. Obviously, I don't have to explain why this would be disempowering for clients to experience. But what I really enjoyed was at the bottom, someone wrote in pencil, and I swear it wasn't me, and sometimes they tell the truth. And to me, that really reflects moving towards harm reduction. So the idea that we're taking into account the nuances that people are experiencing with their substance use as it interacts with the larger social context that I've been referring to. And it's just really important for us to remember as providers, particularly when we're working with marginalized communities, that people, our systems, basically force people to lie to us, if you will. A lot of our folks will lose their partners, will lose their children, will go back to jail if they mention that they were using. There's a lot of punishment built into the system. And so, of course, out of self-preservation, they need to tell us what we want to hear. And so I think that's something we need to acknowledge, is that it isn't that this is creating these character flaws within the individual that exist solely within the individual, but that they are also a product of the larger oppressive institutions that compel them to behave in certain ways. Another reason why we moved to harm reduction is that traditional approaches don't work for some people, right? And I've been alluding to this throughout the talk. And we started doing this work with very severely marginalized people. So people who are chronically homeless with very severe alcohol use disorders were the highest utilizers of publicly funded services in King County. So in and out of jail and in and out of the ER quite a bit. And within this group, we found when we asked folks before they moved into one of the first Housing First programs in America that worked with this particular population, folks told us on average they had been to treatment 16 times in their lifetime. That was just the mean. So that gives you a little bit of an idea. If even one of those abstinence-based treatment episodes had been helpful to them, we wouldn't be talking to them right now. And so we have talked about how traditional approaches don't engage some very severely marginalized individuals. But more recently, and I have some old statistics here, there have been updated statistics that really stay quite in step with these. In SAMHSA in the SAMHSA National Household Drug Use Survey in 2013, they found that 22.7 million Americans needed treatment. Now, this is just the general population. I'm not talking about severely marginalized individuals anymore. And out of these folks, they found that 2.5 million received treatment for substance use disorders. Now, usually they had left that National Household Survey basically to just that. They didn't really ask a lot of follow-up questions, the assumption being on provider side that, oh, maybe it's because of access, they don't have access to treatment, or they don't have insurance, or whatever it might be. But this time, SAMHSA had actually asked people, and they asked the folks, the 90% of individuals who were deemed to need treatment to fulfill criteria for substance use disorder, but who did not get it, they asked those folks, well, why didn't you receive treatment? And 96% of those individuals said they felt like they did not need treatment. So our traditional abstinence-based treatments are not just maybe not desirable or inappropriate for the most marginalized individuals in our communities, but there are a lot of Americans who are in need of substance use treatment and are in need of help who just don't feel like our existing abstinence-based treatment modalities are relevant. And another piece of the rationale for harm reduction is that we have found through a series of studies conducted worldwide at this point that harm reduction, and again, this is a very big umbrella that I'm talking about, but harm reduction does provide an effective alternative in a lot of different cultures, across cultures, and across different kinds of modalities and platforms. We found that, for example, with very severely marginalized individuals, housing first, so providing housing that is not contingent upon abstinence and is not contingent upon abstinence-based treatment attendance, helps people reduce their alcohol use and alcohol-related problems, as well as reduce their utilization of publicly funded services. We've also laid down an evidence base for harm reduction treatment, so a treatment modality, a one-to-one treatment modality that I will kind of briefly review today. We found that larger population-based and policy-based harm reduction approaches are helpful in approaching substance users in terms of large-scale opioid substitution, needleless syringe exchange programs, and antiretroviral therapy programs, drug decriminalization, and of course, as we all know, methadone and Suboxone are becoming the gold standards in terms of treating opioid use disorders. And we're starting to move towards harm reduction very slowly, but in terms of tobacco use, while we're starting to acknowledge that various modalities of nicotine are far less harmful than smoking. Smoking is certainly the thing that kills people, with smokeless tobacco, e-cigarettes, and vaping, and of course nicotine replacement therapy being much less harmful. So there's an evidence base for harm reduction approaches as well. And some of the components that I'll be talking about in just a couple minutes are also evidence-based through our studies here at the University of Washington. So recently we completed a randomized controlled trial of harm reduction talk therapy or counseling, which can be used as an adjunct for medication-assisted treatments as well. And we found that over a 3-month treatment and follow-up period, people who received harm reduction talk therapy experienced a 65% reduction in alcohol-related harm, 66% reduction in peak alcohol consumption. That's when most harm is experienced. Despite the fact, paradoxically perhaps, despite the fact that we were not focused on helping people reduce their actual use. And of course, even though we're not focused in harm reduction on abstinence, we also found that there was a 16%, oh, I'm sorry, that arrow is the wrong way, I need to turn the arrow around, 16% reduction in positive urine tests. So more people were achieving abstinence, at least for a series of days, who were receiving harm reduction treatment than were receiving treatment as usual or services as usual at the site they were going to. So the harm reduction really, I hope for y'all today, can be seen as something that extends our repertoire as clinicians and provides provides services or makes services available and desirable to a larger swath of patients that we're working with. It could potentially bring more revenue into clinics if people are able to work with the larger population of substance users. It's something that could help clinics and providers reach a larger group of folks who are in need of help in their communities. And all of these can be helpful for, I think, primary care practice, but also for substance use treatment centers. So I don't know if there are any questions so far. That's kind of I just wanted in this next section to give y'all a brief rundown on some of the tools that we use in harm reduction treatment so that you have an idea of what it looks like. And we do offer trainings and things like this as well that kind of make this more accessible to providers and give them opportunities to practice it. But I'm happy to take any questions about some of the theory at this point if folks have any. Okay. All right, we'll keep trucking. So harm reduction in practice, I alluded to the fact that we had recently completed a randomized controlled trial of a way of sitting with clients, a way of talking to clients. And so I want to just give y'all an overview of that in the last 15 minutes or so here. So first of all, there's a heart set that we operate with in doing harm reduction work. So there's an openness to the other's values. So the person sitting across from you, their values and their context for use. Compassion or feeling with. This is really tapping into trying to see the world from another person's perspectives. But it expands upon that, and that compassion also in a lot of Eastern traditions is associated with a desire to end another person's suffering. The trick is to end another person's suffering in the way that they would like to see their suffering ended. So trying to tap into what that means for an individual. There's acceptance for the broad range of behaviors that we see in our clients. There's a pragmatism, so doing whatever it takes to help a person reduce their substance-related harm, even if it seems to contrast with a lot of things that we've traditionally done in this kind of service provision. Being really cognizant of that, being flexible with our approaches. I think a lot of those would probably be the case if we were doing really good humanistic, existential, or even motivational interviewing treatments. I think where harm reduction takes it to the next level is with the idea of transformative, wanting to see transformative change happen on our clients' own terms. So really looking to have them reclaim themselves as human beings, particularly folks who've been marginalized in systems of oppression in our society. And really engaging in advocacy, and this can be standing up for clients in staffing meetings. This can be working with housing providers to give clients second chances when they're struggling with maintaining their housing. So really becoming an advocate on behalf of clients who can't advocate for themselves, and helping them to modeling advocacy for them so that they can learn to self-advocate as well. And the tools that we use within our harm reduction approach, first, I would say multidimensional assessment and feedback. So we talk about, we do assess substance use and related harm. I like to use certain measures for this that I'll talk about in just a second. Doing decisional balance. This really helps us get to that point that I was talking about before, assessing people's perceived benefits of use as well as the negative effects, and helping them figure out how can they maximize the benefits of use if they want to continue using but minimize the not so good effects. Assessing quality of life. So again, this is the more holistic approach to clients, understanding what they want to move towards as well as what they want to move away from. And also assessing biomarkers. So these are things that we can feed back to clients that help them see real positive strides in terms of their physical health when they start to reduce their substance-related harm. And these are some tools that we have used to assess quantity, frequency. I think the timeline follow back. So using just a calendar to assess people's use in the past week, it gives you a really flexible tool to use across different kinds of substance use, across different substances and use modalities. Alcohol quantity and use assessment is called the AQUA, and that's a measure we've created to help really assess the number of standard drinks that people consume. And really hone in on what use looks like for an individual. We have a lot of clients who are homeless who are using things like, who are drinking like 211 Steel Reserve. And so they might say, oh yeah, I had 3 beers last night. So 3 beers in my head, I'm thinking 12-ounce Budweisers. Well, they're thinking 3 24-ounce 211s, which are 8.1% ABV. So really that, using a measure that helps us to use standard drinks and to really assess alcohol use more precisely is helpful, especially with clients who are using different kinds of different kinds of alcohol. We use the short inventory of problems for alcohol and drugs, which is a version of Bill Miller's INDUC that was created a few years ago for the Project Match trial, and that helps us look at people's experience of alcohol and substance-related harm across various life domains. We use various measures of health-related and just general quality of life to see if we're helping people to boost their experience of positive things in their life as well. And then for alcohol and smoking, there are some really nice biomarkers that we've used to provide feedback to folks about what their experience of health-related consequences are, and to then be able to track that over time and see how that decreases as they start to engage in more harm reduction approaches. This is just an example of the short inventory of problems. So it's a 15-item measure that's pretty easy to integrate into practice. We like to use this with folks, especially when we first meet them, and about once monthly thereafter in our practice. Then I think another thing that we do that's really important is engaging in client-led tracking. So a lot of the times when we have clients fill out questionnaires in our waiting rooms, or we assess people's, for example, their liver transaminases, it goes into a black box of clinicians do something with that stuff over on the side. And so what we like to do is ask clients what they would like to choose, what they would like to focus on, what they would like to track over time, and then we help them visualize that over time. Gives a more sense of transparent QI for us as clinicians. Are we doing our jobs that we have pledged to do with clients? And also clients get to see successes or get to troubleshoot if things aren't going the way they want them to go. And this is a really very simple example of what tracking progress can look like. So we might have, for the SIP, we might have the substance-related harm here along the y-axis, and then we track that over the months that we're seeing clients so they can see changes in their substance-related harm. We also engage in harm reduction goal setting, and this is not super complicated. I think it's the most simple but really most elegant way to help a person start to move towards positive things in their lives. And subsequently, we found in our research that helps them move away from harmful substance use. So harm reduction treatment goals typically are focused on substance-related harm reduction or quality of life improvement. They need to be precise and well-defined, placed in time and context. We like to schedule in when people are going to actually achieve their goals, and we assess those from week to week. We meet with clients weekly, but this is also something you could do on a monthly or quarterly basis as well. And we want to ensure that harm reduction goals are also doable within the time frame that clients have to achieve them, and that they're doable for clients just generally. The point of harm reduction goals really isn't that people achieve stuff, but it is that they have the experience of success in achieving things, and they start to recognize that they have their own agency and they can move towards positive things that they want to see in their lives. Regardless of how small that looks to us as providers, it might be very big for a client to achieve these things. And so we asked the very simple question over the next blah, blah. For me, it would be over the next week. For y'all in your practice, it can be over the next time until you see a client or patient. What would you like to see happen for yourself? So I would say, we're going to be seeing each other over the next few months. But let's talk about in the next week, what kinds of things would you like to see happen for yourself? Some people call this a goal, a vision, or intention. And we like to stick close to what clients, some people are not as Western oriented, and goal sounds like school. So maybe a vision or an intention that they would like to set for themselves. And someone might say something like, I want to get back to work, right? I'm thinking of a lot of the marginalized clients I work with here at Harborview. Now, this could be challenging for someone. And as a new patient, I might not know what this person's background is and how feasible that's going to be within a short time frame. But typically, we like to be very affirmative. So you'd like to get back to work. Can you tell me more about that? And elicit the story from clients about what that would entail so we get a better read about how realistic that goal is. And so a client might tell us a story about, they're currently homeless, they injured themselves and they couldn't work, and so they became homeless. So I'm starting to know as a clinician, maybe that's not something they're going to achieve in the next week or next couple of weeks, but being very affirmative about that. So you worked in construction for many years. Essentially, you were helping build the city. Now you're wondering if this might be a doable pathway because you're concerned your health might not be what it once was. You mentioned building things with your hands is really important to you, and that is part of your identity. So getting back to work is a great goal for you. It's also a really big goal. So how can we break that down in a way that you can achieve something in the next week that can make progress towards this larger goal of getting back to work? And we help clients, we use a visual to help clients start to conceptualize stepwise change that they can make towards something positive they want to see happen in their lives. We record those goals in our own records, which we track then from week to week. We also provide clients with a weekly goals page that they take with them. Some of my clients like to program that into their phones so they remind themselves what they wanted to try and make happen for themselves in the next week. And then we check in with them over time. And we don't just say, would you like to, did you make that goal happen? Yes or no. We really use a lot of elicitation of stories and provision of strengths-based reflections and affirmations that help to support clients in reaching this goal, particularly if they're struggling with it. Eliciting stories around what they're trying to achieve in their lives helps us to help them troubleshoot. And also we can support and provide affirmation for positive things that they are doing. So even if clients come to meet with me and they haven't achieved the goal that they set out in the last week, I can affirm the fact that they came to see me today, and that's also a step towards their goals and achieving their goals, and that's a really important thing they're doing for their health. So really helping to build clients back up after many years of substance use, chronic substance use, can be one of the most therapeutic things that we can do as clinicians, providing what some have called a corrective emotional experience. And again, one of my clients actually reminded me to say this and said, okay, but remember to tell people it's not just about reduction in substance-related harm, it's also about improvement in quality of life. And that's part of the client-driven pathway to recovery. So encouraging clients to build in positive things that are reinforcing for them in a really old school behavioral therapy kind of way, right? So what do they want to move towards that's fulfilling and fun as well in their lives? We also talk to clients about safer use strategies, and we offer safer use tips based on their primary substance. And I've worked with Mark and Rick and other physicians as well as other clinicians and with community members themselves to come up with these strategies. So we we've developed through our research safer drinking strategies. And we introduce these, for example, by just saying, there are different things that a person can do to change the way in which they use to stay safer and healthier, even if they choose to continue drinking. So there are ways that you can continue drinking and stay healthier when you drink. Things like eating, because it buffers the alcohol's effects on your stomach lining, as well as doesn't get you in that peak and trough kind of experience with your alcohol use. There are ways you can change your alcohol use to make it safer. And then, of course, there are ways you can change how much you drink. With our more physically dependent clients, we talk about the importance of avoiding withdrawal because a lot of clients don't understand that. So if clients are physically dependent and they want to reduce their alcohol use, we really do try and help them consider what that could look like and come up with tapering schedules with them if they'd like to taper or talk about medically supervised withdrawal. And we've created safer use strategies that are very similar for use of depressants, such as opioids, as well as stimulants. We go over this typically in the first session with clients, and then we revisit this and try to start to inject these bits of information, psychoeducational information, strategically in a conversation instead of providing a monologue about what people should do. We're like, if someone says, "Oh, this week I decided not to mix stimulants and depressants," and we're like, "Oh, wow, that's great, because as we talked about, that can pull your heart into two different directions and make overdose more likely. So that's really great that you've been able to make that decision." So trying to interject psychoeducational information versus lay it out in kind of a monologue form. And then, of course, we check in with clients from week to week or over time, continuing to assess their substance use and their the positive steps that they've been able to make towards harm reduction goals and safer use. So that is your brain on harm reduction. And I have resources that I'm happy to share with folks, really great self-help guides and also psychotherapy manuals. And I'm happy to answer any questions, or if people have cases that they wanted to bring up. I think that was.
Yeah, no, thanks, Susan. So we do have a few minutes. What I want to do, though, real quick is, because I know some people leave at 1 o'clock before we get in, I want to do our roll call real quick, and then get into some cases that people may have. So if you can unshare your screen.
Sure.
I'm going to have, I don't know if Betsy's doing the roll call. Looks like she's with us. Betsy, I'll let you do the roll call, and then we'll get back to our cases, case time.
Okay, sounds good. So let's start with Mary Bolton.
Hi, I just joined. I'm sorry I was very late. I was with a patient, but I hope I can get hold of your slides. I'm very interested in the topic.
Oh, great. Thank you.
Yeah, we will post the slides online on our website, the uwictp.uw.edu. Okay, how about Richard Waters?
Yeah, hi, this is Richard, family physician with Neighbor Care Health, and thanks, Susan, for a great presentation.
Hi, how are you, Richard?
Okay, so I have a phone number that starts with 425-412.
That's Harvey. That's me.
That's Harvey?
Yeah. Sorry
Okay.
for being late on another webinar.
No problem, we understand. Okay, and then Unity Care. I'm not sure if you're with anyone, Aaron.
Hi, thanks for the presentation. It's just me this afternoon. Aaron Moore, Bellingham, Unity Care, psychiatrist.
Okay, great, thank you. And then Grace chatted that she's there. How about Kate?
Yeah, hi, I'm Kate Reen. I'm an addiction psychiatry fellow with the VA right now.
Okay, great. Sarah Maris-Swan? So Sarah also chatted. She's an RN with Neighbor Care Health. Okay, great. Ty.
Hi, I'm Ty. I'm an addiction psychiatry fellow here at the VA Puget Sound.
Okay, great, thank you. Vimo.
Jerry Steffens. Joe Press. We really liked the presentation, and we really liked the last couple slides that had the safer drink tip sheet and the safer upper stimulant sheet. We wonder if those are part of a series with others and where we could get those.
I am happy to talk about that. And I know you got to do the roll call, but I'm happy to answer that question. I'll be sure to do that.
Okay, we just have a couple more on the roll call. So I have 2 more phone numbers, and just as a reminder, you can unmute your phone by hitting *6. So let's start with the first one that begins with 253. Okay, let's try, oh, maybe.
Hi, it's Therese Schneider from the American Lake VA.
Okay, great, thank you.
I'm a psychiatric nurse practitioner. I work in the addiction clinic here.
Great, welcome. And then I have another phone number that begins with 360. I think that might be, I'm guessing it's Amy, but.
Hi, is it 676?
Yes.
Hi, it's Elizabeth from Northwest Regional in Bellingham.
I knew I recognized the phone number, so sorry, I guessed the wrong person. And then
nobody from Forks. Nobody
what?
from Forks.
Nobody from Forks, yeah.
Shocking.
I know. And then we have another VHA PUGS. That might be Therese as well. I think so. Okay, I think that's everyone.
Okay, great. Thanks, Betsy. All right, so yeah, we do have some time for some questions for Susan. Susan, I don't know if you want to jump in on those handout questions that Jerry had.
Let me say, this is Rick. I need to run real soon, and I just wanted to make a comment that I hope people, and I think Susan's real clear about this, what having a harm reduction approach lets you work with anybody who's got a substance problem, and regardless of quantity. So much of the time in medicine, because addiction and other drug and alcohol treatment didn't develop within the medical setting, it came from outside and essentially from sobriety centers. So we either had, you either didn't have a problem or you had a problem and weren't available for any kind of treatment, or you were either going to get sentenced to treatment or you're going to go to treatment on your own. And as Susan's figures point out, only about 10% of people qualify for that or end up getting that either through strong arm techniques or through their own 2 feet walking into treatment. So that leaves 80 or 90% of the people who could benefit from an intervention just aren't getting an intervention because what we've had to offer really, people didn't think that it counted. In other words, unless you could identify somebody as, quote, an alcoholic and, quote, get them to get ready to go, you felt like you weren't doing anything or you were a failure or whatever. So I think being able to meet people where they are and negotiate with them around, do they have a harm, do they have an issue they want to work on, and might substances be related to that or not, that allows people to do more risk reduction earlier in the course of disease, as well as meet those people that are part of that project that Mark and I and Susan do downtown, where we're treating people with really super severe alcohol problems and dependence who really don't want to or don't qualify for typical treatment. So you really got 2 kind of populations you can be doing with more of a harm reduction approach than a more traditional approach.
Mm-hmm. That's right.
Yeah, no, thanks, Rick. Yeah, Susan, I don't know if you wanted to kind of get back to the comment about those sheets that you put out there.
Sure. So the safer use with alcohol strategy is something that is a primary component of what I mentioned was our randomized controlled trial that we recently completed. It's also part of a pilot study we had done a few years ago using those safer use strategies in conjunction with Vivitrol or extended release naltrexone. And we're currently also using it in a very large scale Vivitrol trial right now. So it has an evidence base behind it that is good at this point. And so I know some folks are worried when you start to talk about safer use strategies that enable people to use more. We haven't seen that in our research at all. In fact, we've seen that people where we start to engage them around safer use, that actually gives them the message they've started to tell us. And we don't have data on this specifically, but anecdotally and more qualitatively, they've told us that it makes them feel like they're worth saving. So it makes them feel like someone cares about them and someone cares about their health, even though they're continuing to use. And that kind of makes them feel more motivated to try and do things for their health and safety. So that's the context for the development of that. We've expanded that to depressants and stimulants using information that we have as a team, information from clients, information from various organizations that have been extremely good at publishing information about safer use, such as the Harm Reduction Coalition. So we're happy to share these with folks. I will do, because the PowerPoint presentation version is not very usable, but I'm happy to send PDFs of that to Mark, and then maybe Mark, I don't know how y'all might be able to distribute those. So those are available for use. What I would encourage y'all to do if you are interested in learning more about safer use strategies too, there are really great resources on the Harm Reduction Coalition website. And I think particularly for nurses and physicians, that could be helpful talking to folks about the relative risks of, for example, injection drug use and how to shoot more safely and things like that. That can be really, really helpful for folks who are going into the ER a lot with abscesses or have had problems with injection drug use. There are lots of things that you could do as medical providers to help people make safer choices. So the Harm Reduction Coalition website is a really great place of information as well.
Yes, thanks, Susan. If you send that out, we'll be able to distribute that to the group at large very easily. So thank you.
Hey, Susan, quick question. So when you guys are putting all those strategies together, do you ever think about helping? I'm thinking about patients that I've had where encouraging them to disclose to a loved one, that they're working really hard to hide habits and things as one strategy to sort of help them get some support and safety, but also sort of move down that continuum of approaching, getting more motivated to do something about it. So I'm just curious about your thoughts. And I know in the more severe populations, that's not as big of an issue. It's pretty obvious, people that are more sort of overt in the harm that's happening, but maybe on that lower continuum where the harm is less clear.
So it can be helpful, right? It can be helpful. It can also be pretty punitive. It kind of depends on if they have a partner, how supportive that partner is. For a lot of partners, at that point, they feel pretty burnt out because even if people are trying to hide their substance use, it's not, there's usually signs that are happening that create tension in relationships and families and partners among friends. So what I most recommend for folks who are in that position, Pat Denning and Jeannie Little have created a really beautiful self-help guide called Over the Influence. And it's a harm reduction self-help guide. And it has at the end of it a letter to friends and family that I think is really great to help substance users understand what they need to think about if they're going to talk to their friends and family, and how to protect themselves and how to be sure, is this the right idea, and how to go about that. And then it also is a nice letter to be able to give to friends and family to understand a harm reduction approach and to help provide a rationale for it and to show how it's helpful. And what I love about the current literature, just a couple of years ago at RSA in San Antonio at the Research Society on Alcoholism, they did this study that showed that when partners were supportive and helped to reinforce positive behaviors that people were doing to stay safer and healthier when they were using, versus yell at people were, hey, you were drinking too much last night. Why did you do that? But they were like, wow, I'm really glad you didn't drive home. I'm glad you were thinking about your safety. The more supportive partners were, the less people were drinking over time, and the more punitive partners were, the more people drank over time, because that's their primary coping skill. And so that was kind of creating a really bad loop there in terms of their behavior. And I thought that was really encouraging too. So it kind of was a different way of reinforcing if partners can get to a space where they can somewhat remove themselves from the emotional stress of that relationship and can start to provide positive feedback on what is going well, then that can really help lift people up who are struggling. That being said, our society doesn't usually foster that, right? People are like, well, if they got a substance use problem, better get out of there, or tell them if they don't quit, then you're going to leave them. I mean, that's our traditional kind of pop culture approach around that. So that's why I would really refer folks to think about that carefully, think about everything we can do as clinicians could have a positive or negative effect. So we need to think about the relative risks of any kind of intervention that we recommend to folks.
I love both of those suggestions because, especially in the opiate world where you've got lots of folks that are, getting medications from other family members or taking them out of cabinets and things like that, for how do you, as a provider, coach, these folks how to do that. So I love the idea of the letter as a concrete way to sort of think through how would they want to disclose or not in that kind of situation, to sort of get the help in, contingency management with the family around that in a positive way.
Yeah.
So I think and then the other piece I was going to just underscore what you just said that I also love is that idea of being able to direct with partners what kinds of things to reinforce, because I think in primary care we have a nice opportunity for that when we often see patients with their spouses and their partners that they're with, and can give that sort of nice direction the same way we would in saying, this patient has diabetes and, this is what might be helpful is don't give them those kinds of foods, or is there any way you guys can shift together how you do meals? I think you can do the same kind of direction.
Absolutely.
That in a beautiful way where they have that kind of opportunity to do that, right, with the couples that come in. So thank you. That was very helpful.
Thanks. What are some other questions people had? Mary, were you going to say anything? Your box lit up. Maybe not. How about is there maybe a specific clinical type of issue that's come up that might, do you think, well, maybe a harm reduction approach would be a better option for this patient? So any clinical situations that people might have?
Yeah, I've got maybe more of just a general kind of request for kind of what you've seen, Susan, or others. In terms of kind of a lot of what you talked about was focused on alcohol, but in terms of kind of buprenorphine, I say or potentially methadone. I know the public health clinic has been doing kind of their buprenorphine pathway program, where buprenorphine is being used in a very harm reduction manner. How have you seen kind of the change over time? Because I feel like I'm seeing this change from buprenorphine being used in an abstinence kind of as the goal manner to buprenorphine being used more of as a harm reduction. And if you see things on the legislative or policy side that seem to be shifting in that direction also.
That's a great question. I haven't, but clinically I've become more party to that. Just working together with Rick, I work in the chemical dependence. I kind of straddle the line between mental health and chemical dependency at Harborview. I know that it was a traditionally very abstinence-based program. And now, folks are like, well, they're smoking marijuana, but okay, let's keep providing bupe. So I think they're among providers that anecdotally I've worked with, and also working with Joe Merrill over at the Maine Adult Clinic. I know that his primary care program, his Suboxone primary care program, is very much focused on a harm reduction approach. And they recently received a huge grant from SAMHSA to help model that approach to other locations. So I think that's the direction we're all moving in, because it's just the nature of the beast, right? People aren't just like gonna get sober and they're only using one substance. I don't know if that used to be the actual way it was happening, but it's certainly isn't anymore. There are a lot of substances going on. Clients are oftentimes polysubstance using. And so really just trying to assess and evaluate what could help people reduce their substance-related harm and what substances maybe aren't getting in the way of reducing harm. For some clients, marijuana is not really getting in the way, so why do we have to toe a hard line on that? If we can, help them with what is a bigger issue for them, their injection drug use that is landing them in the ER with abscesses, that's the main focus. And so I think I really appreciate that. And I also think, as providers, we need to be aware of just really think things through, because doing harm reduction work, as you all know, Richard, is, it's a lot of gray area. So you're constantly having to think and rethink, okay, what would be, harm reduction versus harm induction? So you have to, I think, really think very critically about that. And I think that's the challenging part about adopting a harm reduction approach, is that you can't just set it and forget it. Everyone get abstinent. If you aren't ready for that, come back when you are. We can't, it's not that easy, right? And so we do have to think more creatively. We do have to think more critically, and we have to pay more attention to the literature as it's coming in about new substances popping up, new synthetics, and how people are using them. But I do think that I appreciate the more nuanced approach. In terms of how that's being viewed at the state levels, I know that the county is very in favor of harm reduction approaches. I'm going to be talking to Brad Feingood next week some more about that. The state WACs are not yet in line. So when we're talking about traditional CD programs, we still have a state law that requires abstinence-based treatment in terms of CD. But I think you have a lot of latitude in primary care and in other settings to do what it takes to meet clients where they're at. And I think that's what we should do. It just requires, you have to constantly be thinking more critically. It's not as black and white to do harm reduction, but it's certainly going to be more approachable for more clients. And it's going to, I think the most important thing we can do as clinicians is to keep people in our clinical care, keep people engaged, because the longer we can keep people alive and talking to us, the more there is that opportunity for positive behavior changes and reduction of harm. And I think the worst thing we can do is, well, if you can't get abstinent from all substances, come back when you can, because they might not come back, right? So I do think we have to kind of think creatively, be flexible, and also engage in real critical thinking about what substances and modalities are really compounding someone's substance-related harm, and what things can be part of a harm reduction approach for that individual.
I think the other thing I'd add to that too, Richard, on the legislative side that's not meeting muster with the science end, is when you're looking at chronic pain versus addiction when it comes to Suboxone and methadone. And so I found a lot of our patients are trying to navigate that really difficult, which is really difficult, because if they get pegged as an addiction case, they're stuck in a methadone clinic for years, and they've been very successful. And I've had these patients, and they come into the pain clinic and they want to say, can I get this prescribed for pain so I can get it monthly instead of having to go in every few days for the rest of my life? So I think that, we're not conveying this care in a patient-centric way, either accounting for people who are successfully treating their addiction and have comorbid pain. And we have these different total philosophies, which also get to Susan's earlier point about class and race issues that are all tied into that, where you look at the populations that are hit who are in the methadone clinics versus the folks that go to pain clinics and get to have their medications every month, who might be suffering with, equal levels of addiction. So I'd like to see our legislation catch up. And, I don't know, Mark, if you also have comments on just getting reimbursement from insurance companies on some of these medications.
Yeah, the fact is that for most people, they can't get prescribed buprenorphine naloxone for pain because the insurance companies will only reimburse that for opioid use disorder, and that can be a real issue. If someone, maybe that might be the best option, just because it's certainly a safer opiate than a lot of other opiates, and it does have some analgesic effects. And so then you're like, sometimes providers almost find themselves fishing for an addiction diagnosis that really might not be there, and that can put that leads to a whole bunch of issues around having addiction diagnosis in someone's chart and where all that goes and all sorts of problems. So yeah, things are evolving. I think things are moving in the right direction, at least around some of the people I'm working with in various pain clinics, but it's still a big problem.
Yeah.
Great, thanks.
Yeah. We have time for one more question before we move on to our case follow-up here, but I wanted to see if anyone else had any other questions or concerns. Yeah, one other comment I was going to make, I too have also seen a lot more kind of buprenorphine first types of approaches where patients are getting prescribed buprenorphine naloxone on a very low barrier type of access type of approach. And have had a lot of success. It's not uncommon previously to where you would hear of clinics having a wait list of a few hundred patients. And that is very challenging. And so I know the VA is doing a lot of work around that area and have been finding some success. And a lot of other places are doing the same thing around the county at least. And I think and I think there's a lot to be said for that approach because it's certainly people are going to be at high risk for overdose without treatment. And buprenorphine is a medication that can be very helpful in that area. And it's going to be very hard for them to change anything without getting something started like buprenorphine. So to me, it makes a lot of sense. But there is that nuance which can be challenging to navigate sometimes. And so what's great is people can have a place like this to come and discuss some of those nuances and gray areas and talk with people like Susan who's able to kind of present here once a year because it's helpful to talk about these tricky situations that people find themselves in. For no one's fault, it just kind of happens. And so it's nice to kind of be able to talk through those things. So any other comments or questions? All right, well, if not, I'm going to share my screen here, and we are going to kind of get into our follow-up case that was initially